Then we need share. We need to include voice because we will see some videos, but the videos will make it at the end of the lecture. Okay. Then we need share screen. Yeah, that should be there. And then reset the timer. Then here. There is some just delay in showing my screen. Should appear soon. Just if you see it, just let me know. Are you able to see my screen? Someone raising his
Yeah,
hand. Eh, eh, you can see my screen, so you can see.
yeah, yeah,
Yeah,
yeah. We
yeah.
can see
Oh,
your
good,
screen.
good, good, good. Just there is someone in the waiting area. I'm not sure if someone can volunteer, and yeah, please, if someone can volunteer and admit the people in the waiting area, that will be very kind from you. Okay, when you're ready, let me know so I can start the 3 minutes. Okay, there is a small extension down there here. Okay, in the case. Okay, so when you're ready, let me know so to put the 3 minutes timer on.
Yeah, yeah. I'm ready. Yeah.
Ready? Okay. Shall we start?
Yeah. Let's start.
Yeah. Okay. Go ahead.
Hi, I'm Sadia, one of the doctors at the practice. Is it Jessica Brown I'm speaking to?
Oh yeah, doctor. Thank you for calling.
No problem, Jessica. So I think you wanted to talk regarding vertigo you've been experiencing.
Oh yeah, doctor. To be honest, it's becoming nuisance now. It has been a week, and I'm really disturbed. I cannot work
Mm-hmm.
at house. I cannot clean. I cannot cook. Uh,
Mm,
yeah, I need help, please, doctor.
definitely, we can have a look into it together. So you said it's been a nuisance. Could you tell me a little bit more? When you say vertigo, what do you mean by that?
Oh yeah, doctor. I feel lightheaded.
Mm-hmm.
Yeah, I feel it's very difficult to describe, to be honest, doctor. But I feel my head is fluffy.
Mm-hmm. Okay. So it's not the feeling of some like the room is spinning around you, or like it's not that kind of sensation you feel.
No,
It's
no,
just the
no, no,
lightheadedness.
no. Yeah, yeah.
Okay.
It's lightheadedness.
Mm-hmm. And did it start suddenly or did it start like slowly, slowly?
No, to be honest, doctors have been creeping up on over a week now. So
Mm-hmm.
I guess it's slowly, slowly, doctor. Yeah.
Yeah. And do you feel it all the time or it comes and goes
Not so all the time.
all the time? Anything which you makes it worse?
No, to be honest, I didn't notice that, doctor. I think it's
Mm-hmm.
always worse. To be honest, it's horrible.
I'm sorry to say. I mean, you've been going through quite a lot with this. It's quite, it looks like you've been coping up. Do you live alone or somebody else lives with you?
Yeah, no, doctor. Since my husband died, I'm living alone.
I'm sorry to hear that. And how have you been managing with not able to cook and clean and
I'm not, to be honest. There is piles of clothes need to be washed, and
mm,
food-wise, I had to order from the
mm,
restaurant nearby. I
mm-hmm,
never like to eat from restaurant, but what to do? I had to. I'm worried that I might have a fall, doctor. My neighbors had a fall
mm,
last year, and
mm.
poor her. She had the hip fracture, and then she got after
Oh,
that chest infection, and she died.
oh God.
So
Oh,
yeah.
yeah. I'm sorry to hear that. Definitely, I can. I mean, is that the only concern you were having, or was there anything else you were worried about apart from the
Well,
fall?
to be honest, doctor, I asked ChatGPT, and
Mm,
it told me, oh, that can be stroke. So I said, oh my God, I need to go to my doctor. I need to see what
yeah.
is that. Yeah.
No, no, definitely you did the right thing, and we can have a we can have a we can discuss about it. So, and apart from ruling out stroke, was there anything else you were thinking we could be doing for you today?
Well, yeah, doctor, just if you can help me to get rid of it, because until when I will
Mm,
feel, I feel my head
mm.
is spaced.
Yeah, 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 definitely. So, so it's just the feeling of being lightheaded. You mentioned it's not. I mean, you don't feel the room spinning. Have you noticed like any movement or anything makes it worse?
No,
Anything?
no, not
No,
really,
nothing
doctor.
like that.
No,
No.
no.
So yeah, sometimes people can feel lightheaded and like feel also some other symptoms. Is it okay if I can ask you a couple of more questions regarding that?
Yeah, sure.
Yeah. Have you had any recent cough, cold, or flu recently?
No, not really.
No, no. Any problems with your ear, like hearing loss?
No, I think my
No,
hearing is fine.
no. Any buzzing in your ear or any other
No,
symptoms?
no,
Any headache?
no, not really. No, no
No.
headache. No,
So with this lightheadedness, do you feel sick in yourself or have you been sick?
no, not at all.
No, no. Any vision problems like double vision or change in vision?
No, not really.
If you mentioned about stroke, have you felt any weakness or any numbness in any part of the body?
No, thank goodness. No, doctor.
No, no, that's good. Any speech? I mean, I can see that your speech looks okay. Any have you noticed any difference in your speech?
No, no,
Like, no, that looks okay. That's good. Any numbness on your face or any other part of the body?
no, not at all.
No, no. Sometimes I mean, this lightheadedness can also be coming from like from your heart. Also, some problems related to that. And any recent racing of your heart?
No,
No. Any sweating?
no, I'm not. No, I'm not a sweaty
No, no,
person. No,
no.
no.
Okay, that's good to know. Any recent change in your weight? You've lost weight or gained weight?
No, I think my weight is constant. No.
Okay, that's good to know. And have you had any? So you mentioned you were worried about fall, and you've not had any fall previously to this, right?
No, no, doctor.
No.
Thankfully,
Okay. No,
I
that's
hope I
good.
will never have. I'm living alone, and
Mm,
that's scaring me, doctor.
yeah. Yeah. Definitely. Yeah. And do you drive?
Well, I do drive, but since I have that, I stopped. I
Mm,
refrained from driving. I said, I don't want to make
mm,
any harm for the others. Although
yeah.
no, and I can't get my groceries. I
Mm,
try even to order online, but then it's a little
mm-hmm,
bit expensive. This Tesco and Sainsbury are very
mm,
expensive slots,
yeah.
so I'm not
Yeah. Yeah.
sure.
Yeah, no, definitely. I think, I mean, that's a good, you've done the right thing of, like stopping driving for the time being. I can see on the notes that you have history of diabetes insipidus and underactive thyroid
Mhm.
and depression. Is that long standing, or is there any of them have been recently been started, or any
No,
recent
that's
medications?
since no, no. I think that's since I was 40 years old.
Mm-hmm. Okay, so there aren't any new medications from, I can see from the, you're on desmopressin and, yeah.
Yeah, thyroxine and the citalopram. Since my husband died, I'm taking the citalopram.
Mm,
But I'm not sure, doctor. It's not written in my notes. I visit your colleague 2 weeks ago because my knees was hurting me, and then he did give me some painkillers and this tablet
mm,
for my stomach to protect it, and they are working. They are excellent, really. He's
very
a good
good.
doctor.
Excellent. So are you still taking them now also?
Oh yeah, doctor. He told me take them
Mm,
for a month, something like that.
mm, okay, fine. That's good. And otherwise, you've not noticed any. So sometimes these medications can cause some like stomach irritation, and like said, that can give some black tarry stools. Any
No,
of these symptoms? No, no.
no, no,
Okay.
no. I didn't notice any change in my
Noticed
bowel.
any.
No,
And have there not been any recent increase intake of any alcohol or
no, no, doctor. Alcohol.
no, no.
I'm not fan of alcohol, to be honest, doctor, because I'm living
Okay.
alone. So maybe
Mm-hmm.
over Christmas, if I want to celebrate the Christmas
Mm-hmm.
or something, I will drink the oat beer
Okay.
or something.
Mm.
But
Okay.
no, I'm not fan of any of that. No.
Mm. So we asked
And
this
I
question
stopped
generally.
smoking, doctor.
Yeah.
I stopped
Okay.
smoking 10 years ago
That's
since my
good.
husband died. Yeah.
Yeah. Yeah, that's very good. You stopped smoking, and so we asked this question to everyone. Any drugs, any recreational drugs? Like it's a common question we ask everyone.
I think I passed
No.
this age, doctor. I'm
Okay.
61.
Yeah, I
Yeah.
know. So, thank you for all giving me all the information. So you were concerned actually about stroke. Actually, I couldn't hear anything from what you've told me today that there were any symptoms or suggesting that you are suffering with stroke.
Hmm.
However, yeah, I mean, and I can see that this has that the lightheadedness has had quite a toll on you with affecting your day-to-day routine activities also. Um, so definitely I think we can I from what I feel from what I have a look at your medication which you recently started on 2 weeks ago for your knee pain and swelling. I think this could be the medications could be one of the reasons you're experiencing these symptoms.
Oh, really? How?
And so already you are on the medication called desmopressin,
Hmm.
and adding that with like the naproxen that is for the pain, and also the omeprazole which is given for the gastroprotection, they can actually uh, they are known to cause symptoms of vertigo.
Oh, really? They can cause me
Mm,
vertigo. Okay.
yeah.
Okay.
So this is one of my thoughts, but I think in your case I would still like to examine you and
Okay.
actually to check your blood pressure to bring you in because of the lightheadedness which you're feeling, and to check the nerves around your face and your ears, and to see exactly if we're not missing out on anything.
Yeah, sure, doctor. I don't
Yeah,
mind. Yeah.
yeah, just to check your blood pressure sitting, standing, and do a couple of tests actually. Even though from what you've told me, I couldn't hear anything worrying or anything alarming from. But nevertheless, it's not wrong if we do examine you in the clinic.
Okay, sure, doctor. So what might be? So you said that this tablet can cause me something. Is it
Yeah,
something serious, doctor?
I I don't think it is something serious. I think they are more prone to cause vertigo. So that's
Okay.
yeah. So that's what I think. So sometimes they can cause some electrolyte imbalance also. So even though you've just used it for some time, actually not a long time, but yeah.
What you mean by electrolyte imbalance, doctor? Sorry.
So sometimes you can lose some salts also, and if losing some salts can also cause some like dizziness. uh, if you're okay, if instead of using these medications, why don't we switch to, have you tried paracetamol before?
Yeah, it's not helping, doctor.
Hmm. And so let me examine you. Have you been to the physiotherapist with this knee pain?
Oh yeah, doctor. He's very, he's just giving me some exercises and just tell me off and go ahead and
Mm, mm,
do your exercises
mm,
and
mm,
yeah, it's the which I can see it in
mm,
the on the YouTube or something.
mm, mm,
I mean
mm,
I don't mind if you want me to do exercises, fine, but
mm.
until when?
Uh, so for the exercises, I'll actually let me see you in the clinic and we can
Okay.
discuss this further.
Mhm.
But in the meantime, if you are struggling with your day-to-day activity, I was thinking of maybe getting in touch with the social services and see if they can arrange some emergency carer
That
for
will
you
be
in the
lovely.
meantime.
That will be
Yeah.
lovely. Mhm. Continue. Yeah.
Mm.
Continue, but
Yeah.
yeah, continue.
Yeah. And so yeah, we can arrange some carers for you and see how things are. And if you do feel, obviously there is a risk of fall also, um, so we can do some, like we can take some measures in order to prevent that. So like there are some ways, like there is I think let's examine you first. Let me examine you in the clinic first, and then let's take it from there.
Okay, that's fine, doctor.
Okay.
Okay,
Thank you.
well done, well done, well done. So, logistic, how she will come?
Oh
That's
yeah.
important. That's important.
Mm. Oh
The
yeah.
logistic, it's important. This exam is not only medical knowledge, it is also problem solving. And the patient problems is
So
your problems.
so
Until you fix it. So she is coming. She drive and she said the doctor told me to come and she had an accident and
okay,
she
fine.
died. What you will
So
do?
maybe we can do a home visit for her if that's possible. If she's not able to
No,
come, maybe
no.
somebody can come.
Then that's abuse of your resources
Mm,
because she's stable.
mm,
She can come, but she needs a delivery. So how
mm.
she can come? Think.
Yeah, maybe friends or somebody can actually, if she doesn't
Okay,
have some
she
neighbors
doesn't
or
have.
somebody.
She doesn't have. All the neighbors are
Any
busy.
neighbors are busy. So maybe a transport, to arrange a transport so we can actually pay for her, or we can arrange a taxi for her.
Well, if she can pay, why she cannot pay? You didn't ask her. Maybe she can pay. You
Mm,
just
okay,
suggest,
yeah.
yeah. You just tell her, can you
Yeah,
take
she
a
can, yeah,
taxi?
she can take a taxi and
Okay,
come.
okay.
Yeah,
She
yeah.
doesn't have money. What you will do?
We'll pay for her taxi then.
So you have a lot of money to pay for her. Mm,
Not from my pocket, maybe
okay.
from the from the practice pockets. Yeah.
Will the partner will give?
Uh, I don't know. I'm running out of ideas over here. Maybe
Hmm.
uh,
Well, yeah.
Self-prescribing.
Who took? Yeah, yeah. Someone is talking. It's good to share. Tell me.
Yes, I was saying the social prescriber can help in that aspect.
Yeah, but then that will take maybe a week.
mm,
You want to see her? Hmm.
Yeah, she can take a taxi.
Yeah, she doesn't have money. What you will do? Well,
Mm.
it's good if you want to pay for her. That's very good from you. But then, I think by the end of the month, if you pay for every patient, then you won't have salary. I'm sure. I'm not. So do you have any other options in your in your practice?
Mm.
Hmm. I'm sure you have community cars.
Yeah, yeah, we do
Yeah,
have
well,
to,
less
yeah.
expensive, but also there is some, there is some
Mm.
charities, the church or any charities already, they are sometimes giving to the receptionist. We pay for you scheme, something called we pay for you scheme. As a charity, is community work, so charity work, they can pay also for her. I mean, it's not always from your pocket. Yeah, if you can pay for her, that's very good from you. That's will a nice, feeling toward the patient. But there is already charities on the community. Okay, you might use your money in different charities. Okay, but there is already charities in the community. We pay for you, and you have already community cars and all over the UK's. Okay, there will be community cars that they are charging very minimal. Okay, so that's one of the options that you can do to
So,
bring her
sorry,
in.
how does that work? Do we tell the patient that they can contact that, or we remain
Yeah,
that
yeah,
one?
there is two ways. Either you will have a phone number and give it to the patient. Either usually the receptionists are very good in that. Usually the receptionist team leader have the responsibility in arranging that. So just assign the team leader to her and he will be able to arrange that for her.
Okay.
Okay. Your time is precious. Don't offer home visits for people that they might be able to come to the hospital. If this to the clinic. If because you will go home visit, that will cost you at least 30 minutes. Yes, 30 minutes mean that you will be able to see three patients. Okay, or finishing 50 laps. Okay, at least. Okay, so again, you need to show that you are, cost effective on the NHS. It's all about cost effectiveness. If that patient cannot come bedridden, okay, her mobility is bad, then yes, that's fine. Go and see her without doubt. Or you can send her also the occupational therapy team, you can send her the frailty team. If you have all of these people working with you on the clinic, then you might be able to, or district nurse can go take her vital signs or take bloods for her. So you need to show that you are, team leader and you can use the team under your hand. You utilize the available resources in a wisdom way, okay? Not in a bad way. Utilizing them in a wisdom way, not in a bad way. Okay, so that's important. Okay, that's important to see how you are thinking, okay, and how you are using the utilities, and the tools under your hand. Okay. Well done, Sadia. So you give me a reflection, what you think, and what you could do better.
Um, I think I'm trying to rule out other causes of lightheadedness, maybe from the data gathering, if she was anemic, orthostatic hypotension. So maybe explore more anxiety because she's living alone and her
Yeah,
husband passed away. Yeah, that's another thing.
that's a very good
Yeah,
op.
could
Yeah,
be one of the reasons of her any. So I asked about racing of her heart, tremors, or yeah, sweating. So that could be, yeah. And have she had any loss of consciousness or any of these? No, but I don't think so. Otherwise, I don't think it was. So yeah, so I think examination wise would have been given a little bit more clear idea what's exactly happening with her. But
so
apart from the
mhm.
yeah,
Yeah, yeah, go ahead. Yeah, continue.
apart from the medication, I couldn't point at anything specific. What's really because she said nothing helps her, nothing. I mean, like, nothing makes it better or nothing makes it worse. I couldn't actually put any finger to anything over here.
That's
So
true.
yeah.
That's
So
true.
I mean,
That
yeah.
will force you to think about what? It's tricky.
Other
All
yeah.
all cases of dizziness or patient coming vertigo or lightheadedness or
Mm.
oozy or wheezy or dizzy, all of these are non-specific terms, which is very challenging, because they are different from patient to patient, and the
So
patient
then
will express different, feelings with the same terminology. Okay, yeah, but you did you did try to understand that from her. But usually, when you feel that the dizziness doesn't relate it to any specific cause, where that should take you.
mm, idiopathic, I don't know.
No, it's different. Idiopathic, well, it can be idiopathic, but there is always, yeah, everything can be idiopathic. No, but that can lead you to metabolic, which you nearly
Yeah.
touching on it.
Yeah,
Metabolic,
metabolic. Yeah, metabolic.
metabolic
Yeah.
cause, yeah, this is systemic cause of dizziness because there is no triggering factor
Mm,
here. Okay, that's important because usually people are usually not thinking about the
mm,
metabolic causes. Always think, oh, orthostatic hypotension, oh, heart problem, arrhythmias, cardiac output
mm,
failure, okay,
mm,
or vasovagal, or stroke, which is
mm,
logical to think because you are trying to exclude, the dangerous things first, isn't it? But
mm,
then there is no triggering factor. Uh, Patient is not malingering, okay? Patient is, this senior patient coming to complain. That's genuine complaint. So, and
mm,
actually, all the if you read the case book, because I'm always telling, try to analyze what the examiner trying to tell you from from the sheet that he gave it to you. He give you 3 minutes not to read the sheet. Well, he knows that you can read it in less than three
mm,
minutes You are a doctor, you are a fast reader, that's without doubt. Okay, so he knows that you can read, but the issue is not to read in the 3 minutes, is to analyze what they need to tell you. So that patient have the central diabetes insipidus. Okay, well, the first thing will come to you
mm,
is hyponatremia, without doubt.
mm,
The first thing will
mm,
come to your brain. Okay, does this patient have a problem with his electrolyte or her electrolyte?
mm,
Autoimmune
mm,
hypothyroidism, again, hyponatremia, is it? Hypothyroidism, hyponatremia are connected. Levothyroxine, desmopressin, citalopram, again, hyponatremia. Yeah, citalopram causing
mm.
hypothyroidism. Naproxen, does naproxen cause hyponatremia or not?
I think it does cause hyper.
It
It
does
does cause.
cause, does
Yeah, it does
cause,
cause. Yeah.
naproxen cause hypertension. Okay,
Omeprazole also causes.
yeah, so yep. So let's talk about the mechanism
Mm,
a little bit. So naproxen also is important cause of high blood pressure. So please don't
mm,
comment on the patient blood pressure and he's on non-steroidal. Try to give him, a wean off period and wash out period before commenting on his blood pressure. And then the electrolytes. Electrolytes are also affected because it causes
mm,
water retention, isn't it? It causes water
mm,
retention and then, through the prostaglandin. We will discuss the hyponatremia next week in details. Okay, and then the omeprazole PPIs can cause hyponatremia. So that is telling you, okay, this patient, might having electrolyte disturbance. Might be, might not. Okay, the only way to know that is doing bloods, and I was hoping that you'll tell me, okay, come, I will examine you also, I will arrange blood for you, but and what are the bloods? I didn't hear that. And always, if the patient have a chronic disease, and
mm,
there is no follow up in your sheet, always consider that in your management plan. Okay, there is levothyroxine and diabetes insipidus. Diabetes insipidus, at least you need to do a yearly urine, you at least a yearly sodium. Okay, at least yearly sodium. And when you are doing sodium, my advice, don't comment on the sodium level without doing sugar level, not a hemoglobin A1C. You need to do random blood sugar. You need to do triglyceride and cholesterol, and you need to do protein, so the albumin and the total protein. Because when we discuss next week about sodium, we'll know what is the cause of pseudo hyponatremia. Okay, and what are the correction formula of the total sodium level in correlation to the sugar level. You cannot comment on a patient that is hyperglycemic, okay, or having uncontrolled diabetes and his sodium is little bit low, that he have hyponatremia, because most probably that's a false hyponatremia, and we'll discuss that next week. Okay, in terms of what you could do better, because actually you did it nice. Well, you was smoothly going through the differential, and I could hear the differential in your in your data gathering, in contrary to the last week case. So that you did it nicely, and I find it going smoothly. But what I feel that you need further improvement in is the ending of the case. I do appreciate that you was running out of time, so you start your management plan around 4 minutes or 3 minutes and a half, which is not optimal time. But I think because you was little bit thinking, oh, shall I go? Shall I pass the differential diagnosis? There is nothing there. Maybe I'm missing something. No, you need to be quite confident. Okay, if you cannot find anything, okay, then there is nothing. And okay, there is the dizziness doesn't have any trigger factor, that's fine. Be confident and consider it as metabolic cause. Don't let the hesitation, destroy your the second half of the consultation, because it carry most of the marks. The second half of the consultation carry most of the marks. And I'm sure if you had enough time, you will formulate a better management plan. So what you
Mm.
can do with difference in your management?
Basically, give her reassurance that it's not stroke,
Yeah, so the
and
first thing, you
yeah.
addressed her concern, and that was good.
Mm.
Okay. And
And then she wanted some things. I think she wanted some support regarding her daily living activities and
yeah,
some treatment for her lightheadedness.
yeah, yeah.
So
So how you would address that? So first it's not stroke, but then they will tell, okay, well, to be honest, I have a couple of thoughts that what might be causing it, but the nearest thoughts in myself, you might have, as you said, don't say electrolyte disturbance, please. Say, problem in the salts in your blood, because some of your
mm,
tablet can cause you low salts. Okay, that's some of the tablet that we give you, like naproxen and omeprazole. So what I suggest, firstly, we might consider stopping these tablets and then give her alternative for the painkiller. So what you will use? Yeah, paracetamol. Okay, I don't mind, but you know that the osteoarthritis of the hand and knees, what are the first line treatment of it?
topical non-steroidal.
Okay, so why we are not using it? Um, Less side effects, very cheap, very convenient to the patient. Okay, I will give you
Mm.
some ibuprofen gel. Okay, yeah, the 5% over the counter, to give her 10% is not over the counter. Okay, give
Yep.
her ketoprofen gel. Okay, consider capsaicin if you can, if she can buy it over the counter, over Amazon or something, because she can get it. Yes, it's dodgy a little bit because it's not, we are not writing the concentration, but it might be effective. Why not? Okay, so and then
Then bring her in, take her bloods, and
yeah, you will not
verify
yeah,
the
if
diagnosis.
well, if you will be able to take the blood, that's good, well and good, if you have time, but it's 10-minute consultation. Yeah, so arrange for her bloods, but you need then to tell
Mm.
her first. We said, telling the patient, I need you to come for examination will not guarantee you to have a good mark, because you need to know, you need to show what you want to examine. So what you would like to examine in this case?
Examine her nerves and neurological examination, and examine her
You will examine the ear without doubt.
the ears.
Yeah,
Yeah, the ears. Yeah.
yeah, neurological exam, and very
Mm.
important thing, please don't forget. Very important thing, because if you start to
Vascular.
listen, yeah, vascular, yeah, vascular mean blood pressure, lying, standing, and
Yeah.
please, in any cases coming with dizziness or fatigue or what else, very important. You need to use your stethoscope.
BMs. So
No,
yeah.
no, but yeah, BM's okay, that's fine. But then the patient will tell you, well, when I'm eating, I'm fine. When I'm not eating, I'm
Carotid bruise and
yeah, please, carotid bruit,
yeah.
aortic stenosis, because in that age,
Mm.
aortic stenosis is very common. Okay, and anyone knows if the patient have severe aortic stenosis, what will be the next step? Because you can hear it, you can hear that the patient have severe aortic stenosis or not. So what you will do next if the patient have severe aortic stenosis?
Refer to the cardio
Yeah,
surgeon.
most probably
TAVI.
so you know what the cardiology will do?
TAVI or whatever.
Yeah, TAVI
What is
can be, but the cardiology will not do it. The cardiology will do
it?
echo, see the transaortic
Echo, yeah.
gradient,
Mm.
and then he will refer, okay, either to
Mm.
tertiary care center or cardiovascular, cardiothoracic surgeon. So they can do it. Or if they have the capability, sometimes cardiology can do TAVI. So it
Mm.
depends, okay. But usually in a tertiary center, especially if the patient have old age. And please don't think old age alone is an exclusion criteria for TAVI, because I have a patient that she's 91 years old and the cardiologist decided to do the TAVI for her. It depends on the physical capacity of the patient. This is one,
Yeah.
and the echocardiography and the transaortic gradient. Okay,
Mm-hmm.
so yeah, so if the patient is not bedridden, okay, and she is able to function, even if it's not great function, let the decision to be through the cardiology, because I was astonished that they did it to 91, and that make a big difference for her. Okay, so please use your stethoscope. You are a doctor, yeah. Your exams is through the video calls, but this doesn't mean that you need to forget about how to examine the patient. So you need to listen to the patient neck, carotid stenosis, and the aortic also ejection fraction, okay, for denoting the aortic stenosis. Surprisingly, that patient that it's not this patient per se, it's another patient. She had a combined aortic stenosis and carotid artery stenosis, internal carotid artery stenosis, but it was less than 50%. So the treatment was for the aortic stenosis TAVI, for the carotid stenosis just antiplatelet.
Conservator.
Yeah,
Yeah.
just until, because it's less than 50%. Okay, and then what blood you would like to do?
So again, electrolytes, use
Yeah.
any, yeah, and
No,
full blood
electrolyte is
count.
a lot. No, don't say electrolyte. Electrolyte is a lot. What you want to do?
So full blood count,
Okay.
use any
Mm,
sodium, potassium,
yep.
magnesium, um, her glucose, and
Yep.
check for triglyceride, lipid profile,
Yep.
check for her thyroid function test,
Yes,
and
yes,
then
because she
yeah,
is already hypothyroid. Please check. Well, one
yeah,
of the
and her
causes of the
albumin,
hyponatremia and yeah, albumin, yeah.
yeah, albumin, sodium, urine osmolality,
No, 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 not
sorry,
that much. Yeah, urine osmolarity, plasma osmolarity will come.
hello.
That time will come. Yeah, hello.
Hi, I'm Chetna.
Yeah, please, Dr. Chetna, can you mute yourself?
I can hear you.
Dr. Chetna, can you mute yourself? I'm not sure where she
I'm
is.
Chetna.
I'm
Hi.
so sorry, doctors. Just 1 minute.
Oh,
Dr. Chetna,
bad day, isn't it?
can you mute yourself, please?
Mm, yeah, how are you?
I'm not sure where she is. God damn.
Yeah, I know. I know
Oh
this
my God,
feeling.
this if
Well,
they
we'll get there.
I hope they will not say
I mean, it
anything.
has to be the endpoint. The endpoint has to be a pass, isn't it? And we just
Uh,
need to aim for the green tick, really.
so anyone, I cannot see where is she, to be honest.
Yeah.
Yeah. Yeah, I think. Okay. Sorry for that, doctor, but that can happen. Yeah. So where we was? Sorry, because I lost the track. I'm so sorry. Yeah. So we said that the next step after blood, what we will do. Oh yeah, yeah. We was talking about the urine osmolarity and the plasma osmolarity. Well, urine osmolarity, plasma osmolarity will be the next step if the patient have hyponatremia, isn't it? So don't don't over investigate, because also that's not good. Okay, either in the real practice, neither in the exam. So urine osmolarity, plasma osmolarity will be, will come in, in the proper time if the patient have persistent hyponatremia, and we will learn how to read them. And it's an important tool to know how to read the plasma osmolarity and the urine osmolarity, because it's not an easy, and I will explain that in details next week. Then the next step will be.
So obviously we need to review her back after she stopped her medications, and we have changed it to different ones. So maybe a follow-up,
Yeah,
and
yeah,
yeah, and then
that,
to involve social services and social prescriber team, how we
yeah,
can assess, like risk of fall, and maybe to the if
yeah,
there is any risk of fall, and maybe if she needs occupational therapy,
yeah.
to in the meantime to like to review her while she is getting better. And yeah, if I mean we can tell her to use like anti the socks, uh, like the what is it?
Elastic stocking, if she had,
Yeah,
orthostatic hypertension, probably, maybe yes,
yeah,
maybe not. But again, we still didn't reach the point of
anti-slip
diagnosis.
socks.
Yeah,
Yeah.
yeah, it can be. That's completely right. Okay, so yes, social services to try to find carers for her,
Mm,
uh, for risk assessment and asking the OT to come and see her. You may offer her lifeline. Okay, that lifeline is something very important for patient living alone. And then and then the logistic, how she will come to the surgery, and then the follow-up plan. Okay, so just that's the last bit of the management plan needs to be just reinforced. Okay, re-tightened, and then and that will never happen except if you reach the management plan on 6 minutes. Okay, I think in this case only your issue was that you was not confident enough to move forward. Okay, no, you need to be confident enough to move forward. Yes, you might not find any trigger to her dizziness from the symptoms because it's metabolic. So coming back to your opening statement was excellent. You used pre-existing information, you introduced yourself. Okay, you did a certain. So usually when I'm taking the history of any dizziness, sorry, case, I'm first asserting what the patient mean by dizziness, which you did it. You did what the patient mean by dizziness, but I'm always trying to categorize the dizziness into three categories. Okay, or vertical, three the categories. Is it disequilibrium? Okay, so does the patient have history of fall or frequent fall from the beginning? So this means that most probably there is a problem in her balance center. Okay, there is a problem in either proprioception or brain, or problem in the brain. So I will, oh, that's an alarming sign. If she is having frequent fall, no, this patient need to be seen. Like, I need to be seen soon, okay, or me even to go and see her, okay. So if you have recurrent fall, that shouldn't be taken lightly. And then the other thing, okay, or is it spinning? Okay, spinning. This means it's vertigo, and the vertigo have, multiple differential. Is it central? Is it peripheral? And we will go through them one by one. And then, or is it dizziness, fluffiness, fainting, syncope? Okay, that's also have its own differential, and you did go through that. And then timing. So if it's dizziness, then what is the timing? Is it persistent or intermittent? If it's persistent dizziness, okay, that usually is a metabolic cause. Is If it's intermittent dizziness, then okay, that's non-metabolic cause. There is something else happening there, either cardiovascular, either vasovagal, or autonomic, disturbance, either neurological. And then I will go through the differential. Okay. And then what are associated symptoms? As you said, any weakness, any numbness, okay, any problem with the hearing, any problem with the palpitation or chest pain, okay, the associated symptom. And then I will go after that to the past medical history and medication. This is the steps where I'm going through the dizziness. Okay, and according to the answer of the patient, I will be able to be directed which way I will go through. And then after that, I will ask about the idea, concern, and expectation, which Dr. Sadia asked about them very nicely. And then the psychosocial and the psychosocial, okay, who's living with drugs. Okay, maybe the drug of abuse, probably I will, yeah, but it might be important, but with that age group, it might be not that important. Okay, alcohol is important here. Do you know why? Anyone know why alcohol and smoking is important in such case? In this case particularly, no? Anyone know why hyponatremia is or probable hyponatremia important to ask about alcohol? So because there is two couple syndromes called. So first syndrome is called, so you need to ask about alcohol, you need to ask about what she is eating. Okay, so alcohol there, because there is something called beer bitomania. Beer bitomania, a patient who's drinking beer per se, okay, can have hyponatremia due to the ethanol and the, and the constitution of of the beer itself. Okay, so I think the beer is made from parsley and from wheat, something like that, and there is specific substance in the beer itself can cause hyponatremia. And then the other thing which is eating, because there is also tea toast syndrome, tea toast biscuit syndrome. Okay, if you are eating a lot of, drinking a lot of tea and drinking a lot of caffeine as well, that will make you be more water than salt, and that will cause you having a hyponatremia. Okay, and then going through the management, and we discussed the management. Okay, I will just go through the differential of the dizziness in general. Okay, and then we can see some of the videos. Okay, rapidly. If anyone have any questions until now, I'm happy to answer. No, no questions. Did is my screen is clear? You can see my screen, is it? No? Yes? Can anyone
Yes.
answer, please? Yeah, yes. Okay. So in general, this is how I'm thinking about dizziness. Is it vertigo, lightheadedness, or disequilibrium? And vertigo is illusion of movement, spinning. Either the patient is spinning, either the room around is spinning. Okay, usually associated with nausea, and that the causes is the disruption of the vestibulobasilar system. Lightheadedness and syncope, usually is transient hypoperfusion to the brain, and this equilibrium is a problem in the proprioception and the central nervous system. The causes of the vertigo will come to them in details, because I need you to to go through that approach, but I need to go first through the dizziness and how we can approach dizziness, okay, which is the syncope or syncope. And it's very important from the start to know if the patient lost consciousness or not. Because if the patient lost consciousness, okay, and the loss of consciousness was more than 5 minutes, not transient, more than 5 minutes, you need to exclude the presence of a stroke, okay. And then you need to analyze pre-stroke, during the stroke, and post-stroke. And one of the most important questions that you need to ask, okay, if there is a history of probable stroke, or either tonic-clonic or myoclonic seizures, because the problem is tonic-clonic could be easy. The patient, the people around the patient will come say, oh, he was fitting, he was funny, okay, he was having spasm and relaxation, spasm and relaxation. Okay, so that you will, but if the patient coming with myoclonic seizure, okay, that will be tricky. Okay, and then you need to ask about, post-ictal symptoms, okay, thoughts paralysis, which the patient will have confusion, okay, after the attack of seizure for, 30 minutes, 1 hour, okay, rather than the normal syncope. So normal syncope, patient will have retain his consciousness completely after the loss of consciousness by few minutes. Okay, so the thoughts paralysis and thoughts and post-ictic syndrome is important to differentiate between this and that. And biting the tongue as well, and incontinence also one of the important things. Please don't mix, because that's a lot of when I was in the emergency department, there is a misconception between the seizure and the VTAC or tachyarrhythmias, or even bradyarrhythmias, because bradyarrhythmias can induce seizures. So if the patient come with a seizure, also try to analyze, so the pre-seizure period, did he have any heart racing or not? Because it's not uncommon the patient will have a transient VTAC or VF, and that will induce a seizure for him, okay, because of the hypoperfusion of the brain. Okay, one of the things that the brain react to hypoperfusion is by having a seizure. So this is the differential. So the syncope, as we said, is transient loss of consciousness due to hypoperfusion and spontaneous recovery, and spontaneous rapid recovery, okay, not prolonged recovery. Prodrome and pre-syncope period is important, and then the causes of the syncope or fainting as a reflex syncope is which is mean inducing the vagal tone either through patient is prolonged standing or have severe pain, especially abdominal pain or emotional stress, blood transfusion, blood withdrawal, or coughing or sneezing. One of the things that you might consider it is the carotid sinus hypersensitivity. So one of the cases that I met in my in my years of experiences were males that coming to shave. When they are shaving and they are touching the carotid sinus, they will have loss of consciousness and syncope. Okay, the other things is people who when they are when they are flexing their neck, okay, they will have loss of consciousness and syncope, and that will trigger your suspicion of the carotid sinus hypersensitivity. um, Usually the reflex syncope is the most common cause of syncope, and then the second common cause of syncope will be orthostatic hypotension or orthostatic syncope. Okay, and that you need through your questioning to ask about volume depletion, how is the fluid intake for the patient, okay, is it drinking enough water or not? And the other thing, if the RT or if they are in any medication can cause hypotensions, okay, like alpha blocker, diuretics, antidepressant, antipsychotic. Do anyone know why antidepressant and antipsychotic can cause orthostatic hypotension? Anyone knows? Anyone knows from the doctor listening to us? Even if it's wrong, just participate. No?
By causing hyponatremia, Siaga?
Well, they are causing hyponatremia, but that won't be the first, the first mechanism of action of causing, orthostatic hypotension. Any other thoughts?
Anticholinergic.
Anticholinergic, yeah, yeah. They're having alpha blocker anticholinergic
Allergic
effects. Yeah,
blockage.
anticholinergic
Yeah.
effect. Yeah, yeah. The other thing is the autonomic failure. So patient with Parkinsonism, okay, or diabetes or chronic alcoholism, please be aware that by the advance of the disease, they will get autonomic disruption, okay, and it's very important, to check that. So especially Parkinson's patients, okay, they are suffering from their static hypotension and they will have frequent fall, and unfortunately is just a simple tweak in their medication can help them. And the diabetic autonomic disruption is also one of the things that patient usually in the with the autonomic disruption and diabetes will come also with GI. So if the patient have frequent GI symptoms, frequent reflux symptoms, frequent abdominal pain or abdominal disturbance, and he's diabetic, think about autonomic dysfunction and try to check his blood pressure lying and standing, even if it's young, because it doesn't matter how young is the patient, it matter how long is the patient have his diabetes uncontrolled. Okay, and the most dangerous is the cardiogenic one. The cardiogenic one is fatal. Okay, so if you miss it, sometimes patient, can put his life in danger. Okay, so either bradyarrhythmia or tachyarrhythmia, or the most important thing with elderly people, okay, is listening to their aortic stenosis, aortic area, which can be, can you can hear the ejection systolic murmur of the aortic stenosis. And syncope mimic that, as we said, okay, the either patient have psychogenic, okay, pseudosyncope or the seizure. Okay, these are the differential, and we gone through that. The most important thing here in that algorithm is if it's more than 5 minutes, always think about seizure. Okay, always think about necrolepsy and alcohol intoxication and blackout. If it's less than 5 minutes, okay, think about other causes of syncope. And that is differential about how to differential about the three things of syncope. What I will want to discuss now is the vertigo and what is the causes of the vertigo, because that's important. And then, uh, some of the neurological tests that you might conduct if you saw the patient. So So vertigo, which is full sensation of rotation of the environment, or the patient have full sensation of rotation of himself. Okay, and that means that either the the balance center is disturbed, either central nervous system, either the peripheral balance system, which is in the inner ear. So either the labyrinth or the vestibular system is disturbed, and the most common cause of that is benign paroxysmal vertigo. And with the benign paroxysmal vertigo, it's usually short-lived episodes. Patient will say, okay, I feel vertigo when I'm turning in the bed, okay, and it's always, few minutes, not more than that, okay. If he started to report that there is an hearing symptoms, okay, loss of hearing, as well as ear fullness, so that will lead to Meniere. And Meniere, the episode is saying, yes, it's coming episodic, coming in episode attacks, but it's lasting more, okay, with from 1 hour to 20, from minutes to hours, okay. The other, the perilymphatic fistula, usually they will having a history of trauma. Cogan syndrome is a very rare genital, very rare genetic disease. I don't think you need to know about it. Uh, if the patient have symptoms of common cold, as Dr. Sadia asked, common cold or viral infection, you need to, so put of one of your differential is vestibular neuritis, okay, or labyrinthitis. Did anyone know what is the difference? How you can differentiate? Although both of them have the same treatment modalities, but how you can differentiate between vestibular neuritis and labyrinthitis?
By hearing
Anyone?
loss.
Hearing loss. Yeah. So labyrinthitis L, okay, mean that there is hearing loss, and then that will lead us to something. So let's finish first the acoustic neuroma, and then we'll discuss how we can explain benign paroxysmal vertigo for the patient. How we can explain Meniere, because all of this is a potential case that you will see every day in your life, and also. And hence, it can be a potential case in your exams. Okay, so acoustic neuroma, which is benign tumor, okay, usually will come with with hearing problems and vertigo, plus that other cranial nerve will be affected, namely the facial nerve. Okay, so if a patient have facial paralysis with the hearing problem, then always think about acoustic neuroma. The other thing is Ramsey-Hunt syndrome. We have a video of regarding Ramsey-Hunt syndrome. It's herpes zoster oticus. Please, return to it because it's important. It's common to differentiate between Pill's palsy and Ramsey-Hunt syndrome. So, if anyone can volunteer how they can explain benign paroxysmal positional vertigo, how you would explain that to the patient? Anyone? No? Anyone will volunteer? No? Anyone know what is the mechanism? Okay, go ahead.
Hmm.
Bless you. Would you volunteer,
So
Sad? Yeah.
yeah, so it's a condition where you where one experiences short episodes of intense dizziness when the head is moved because of tiny, like some tiny fragments in your inner ear are as they move around. So that actually correlates with your head movements, and that causes you the dizziness.
Well, that's right, but the patient will not completely understand that. So you need to make it to the narrative of the patient. I would explain that to the patient the same way that you are saying. If I have a diagram and I will show him, what is otolith and what is the otoconia and what is the hair cells and all of that. But then that's not applicable in each case, okay, because usually I'm doing that. I have I have diagram in my clinic to explain that, but then that will not be applicable for a patient you are talking with him on the phone, for example. Well, usually what I'm saying, okay, we have thickness, the inner ear, which is one of your balance center, contain a fluid responsible in your balance, and as you are growing older, okay, or I do appreciate your age, this fluid become thick, and we need to make it more fluidy, okay, and then to restore your balance again. And we have a very good exercises to do that, and then go through the diagnostic test, which is Dix-Hellpike, and then the Epley maneuver, okay, which are the other way to, to treat the benign paroxysmal vertigo. And then or if the patient have issues in doing that in the clinic, the Epley maneuver, we can do banded Daroff, exercises. What about Meniere? Anyone can explain Meniere? No? Anyone can explain Meniere to the patient? So for me, I'm saying excessive fluid in your inner ear, which is the endolymph. Okay, so I'm telling you excessive fluid in the inner ear. Okay, and that will lead to hearing affection and also the ringing sound in your ear and the episode of of vertigo. Okay, or episode of dizziness. Okay, however, it's we can control it. We can we can control it, and then I will start to tell him, okay, how we control it and what is the treatment of it. Did anyone knows how we can control Meniere? What are the treatment of Meniere? How you can help patient with Meniere? Do anyone knows? Yeah,
Beta histone prophylactic treatment.
the beta
Um,
histone is prophylaxis. What about the acute attack?
Prochlorperazine or
Yes, Stimetil. So Stimetil, sometimes you can give a Stimetil, you can give ondansetron for the emesis. That's right. Sometimes we can give, is labyrinthine sedative, okay, in general, labyrinthine sedative in the acute attack, which is either you will give Stimetil, either you will give ondansetron, okay, because ondansetron have sedative effect on the labyrinth. Either you will give some people will need to have diazepam or an IV fluid. So, and the prophylaxis is the beta histine as well as lifestyle modification. So, caffeine decrease, salt decrease, okay, increase the fluid intake, decrease the caffeine as much as you can, and fizzy drinks. That's also important. Lifestyle modification for Meniere disease. Vestibular neuritis and labyrinthitis, it will be, reassure the patient that will go within 1 to 2 weeks, and then some of patient you need to admit them because they are, aggressive symptoms, and they need to also again labyrinthine sedative, namely, Stimetil, ondansetron, benzodiazepine, and IV fluid. Okay, the if there is other neurological symptoms, then you will think about the central causes, either vascular or vestibular migraine. Vestibular migraine, the patient will come with headache. Okay, so that when Dr. Sadia asked about headache, that was very good from her. That's an excellent. Okay, but do we know how to differentiate clinically between these, the central causes of vertigo and non-central causes of vertigo? Or we are interested to know that, or we don't, or not interested to know that. So, did anyone know about hint tests? Hint tests
do you do this in your
in my
practice?
clinic? Yeah, yeah, yeah.
Yeah.
I'm doing it. Yeah. So, hint test is I will consider as important, to be honest, because the issue is to know how to, you know, to first to perform it. The second thing, how to be able to interpret it. Okay, which is important. Important because according to the result, you will decide you send him to the hospital, or you will treat him in the community. Okay, central cause hospital, the preferred cause community. Sometimes it's difficult to, still you are not 100% sure, then you will refer. But if you can do it and you find it most probably is a preferred cause of nystagmus, then keep it in the community. Why you will send him to the hospital? Again, the issue is when to do the head test and when to do Dix-Hellpike maneuver. So Dix-Hellpike maneuver, usually the patient have an intermittent vertigo. Okay, intermittent vertigo, you will do the Dix-Hellpike maneuver. But if the patient have continuous persistent vertigo, this needs a hint test. And don't do a hint test or Dix-Hellpike maneuvers and the patient have only dizziness. You need to confirm that he have a vertigo. This is one, and he have nystagmus. This is number two. If the patient doesn't have nystagmus, you don't need to go through all the hint tests because that will be misleading to you. So it's mainly for nystagmus patient. Patient have nystagmus, do hint test. Patient have intermittent nystagmus, then you will do Dix Hillpike maneuver. We will go through. There is a good videos. We will see them together. Okay, and uh, that will have it in details. That's algorithm in causes of the vertigo. Namely, the timing is the most important. So if it's short-lived, acute short-lived episode associated with your movement, is benign paroxysmal vertigo. Okay, is it if it's coming on with hearing loss, okay, and staying from minutes to hours, then that will lead you to a probability of Meniere's disease, especially with tinnitus. If it's persistent, okay, and progressive, is either labyrinthitis, vestibular neuritis, or stroke symptoms, okay, and with the stroke, you need to do the hint test and see if it's central or peripheral, okay. um, we already spoke about that in general. I want to show you some videos, okay, and how to perform the Dix Hillpike maneuver and how to perform the hint test. Okay, so let's see. Please. So that's here the hint test in details. Okay. We'll finish soon. Just
The
the
HINTS exam
videos.
and vertigo. This video is about who to perform the HINTS exam on, how to perform it, and how to interpret the findings. The HINTS exam is used when a patient presents with many hours or days of ongoing continuous vertigo, nausea and/or vomiting, some difficulty walking. Their vertigo gets worse when they change position, such as going from lying to standing, and importantly, you can observe spontaneous nystagmus. Most of these patients will be suffering from vestibular neuritis, a benign cause, but some will be having a stroke. The HINTS exam is used to reliably diagnose vestibular neuritis and thus rule out stroke. There are three components to the HINTS exam: nystagmus, test of vertical skew, and the head impulse test. Nystagmus you observe in primary gaze, where they're looking straight ahead, and in lateral gaze, where you ask them to look to the left and right. In this normal volunteer, she has no nystagmus. Now, when you ask them to look laterally, they might fixate on your finger if you put it there or something on the wall. So in order to take away fixation, which can suppress the nystagmus seen in vestibular neuritis, you can place a piece of paper between their head and the wall and ask them to look at the wall as if the paper isn't there. That takes away fixation, and you might see nystagmus, which you wouldn't see without the piece of paper. In this patient with vestibular neuritis, observe his nystagmus.
Just look to the left again. And then to the middle and to the right.
Here it is again. When he looks to the left, his nystagmus increases, it's left beating, and there's a rotatory component towards the left, and it increases when he looks to the left. You can see the torsional component, and when he looks to the right, it lessens, but the fast component is still towards the left. So it's unidirectional nystagmus. It doesn't change direction. In the HINTS exam, this is reassuring. Compare that to this lady who, when she looks to the right, she has small horizontal nystagmus with the fast component to the right. I showed this short clip twice just to see the little rightward beating nystagmus. And then when she moves more central and to the left, you can definitely see that her nystagmus is now beating towards the left. So she has direction changing nystagmus or bidirectional nystagmus, and that's worrisome in the Hintz exam. The next component of the Hintz exam is the test of skew. You observe this by doing the cover-uncover test. You simply take your hand and place it over the patient's eye and move it to cover the other eye and observe if there's any vertical movement of the eye when it's uncovered. In this patient, observe how when I first take away my hand from his right eye, that the right eye will go medially and upward. And then when I take my hand away from the left eye, it goes medially and downward. It gets a little less as we go along, but there's definitely some vertical skew deviation, which is worrisome in the Hintz exam. Upward and medially, downward and medially, upward again. So this abnormal vertical skew deviation is worrisome in the Hintz exam. The head impulse test will be abnormal if you have vestibular neuritis. The head impulse test is looking to see if you have a nerve problem. And if you have a nerve problem, you probably don't have a brain problem. So it's a little counterintuitive in that an abnormal finding is a good finding. In order to perform the head impulse test, hold onto their skull, have them look at your nose or the camera, and then move their head back and forth until you're sure that their neck muscles are relaxed, and then in a random fashion move their head briskly to the midline from maybe 20 degrees out. What you're looking for is an abnormal catch-up saccade, which I'll demonstrate shortly after this normal volunteer. So again, holding onto the skull, moving the head slowly to relax them, and then moving their head briskly to the center and looking for any abnormal movements. Her eyes remain completely fixed on the camera, and that's a normal thing, which in a normal person is good. If she had a acute vertigo lasting hours and days in nystagmus, it would be bad. Here is an abnormal head impulse test. Notice how this man, initially you can see some nystagmus when he looks to the left beating nystagmus. Then when his head is turned to the right, you'll see the catch-up saccade. This is normal, that one. The next one will be the catch-up saccade. Did you see how there's a larger movement of the eye from the right to the back to the midline? That's an abnormal head impulse test, which is reassuring in the Hintz exam because you're showing that he has a nerve problem, probably doesn't have a brain problem. Here's another one. Again, when his head is moved to the left this time.
Yeah, so I think that will be more than enough for the hint test. I want to go to the branded Darf exercises, okay, for the patient. Usually I'm sending them this video to do it at home, okay? So just a rapid, understanding what is the branded Darf exercises and how you can tell the patient. Just make sure when you are doing the head impulse test, make sure that the patient doesn't have any cervical spine problem, okay? Otherwise that will exacerbate his symptoms.
This is Brandt Daroff habituation exercise. Begin this exercise sitting on the edge of your bed or couch. It is recommended that your feet be able to reach the floor comfortably so you can easily steady yourself when you return to the sitting position. Sit in the middle of your bed so you have enough room to lay down to each side. Turn your head 45 degrees to the right and quickly lay down on your left side. Allow your neck to relax with the back of your head supported by the bed. Wait for dizziness to subside, plus 30 seconds. If you are not dizzy, wait for 30 seconds. Quickly sit back up and wait for 30 seconds. Turn your head 45 degrees to the left and quickly lay down on your right side. Wait for dizziness to subside, plus 30 seconds. If you are not dizzy, wait for 30 seconds. Quickly sit back up and wait for 30.
Yeah, so the other two tests, I know, I'm so sorry if it's a long lecture, but just the other two tests is the Epley maneuver and Dix-Hallpike maneuver, okay? So because also you need to do that in your, you know, in your practice, like, and that's important for day-to-day practice. Okay.
Could this invention end expensive trips to the eye doctor? These revolutionary self-adjustable glasses are taking the world by storm. They let you achieve a sharp
Benign paroxysmal positional vertigo is an amazing condition. The reason why is when you see a patient with vertigo, you can perform a manoeuvre which will make the diagnosis, and then you can perform another manoeuvre which will fix them. When doing the Dix-Hallpike manoeuvre, I always go through with the patient what I'm about to do. I do this regularly, but to a patient this is something that's very new and it can be a little bit scary for them. Something I find useful is for the patient to fold their arms before I do the Dix-Hallpike manoeuvre. The patient's head is turned 45 degrees towards me. They are then lowered backwards so that their head is extended about 20 degrees over the back of the couch. If a patient has benign paroxysmal positional vertigo, you will often see their nystagmus within 20 to 30 seconds. Occasionally, the nystagmus will be seen up to a minute after their head has been extended. In view of this, if you really do feel that there's a strong history that would be suggestive of benign paroxysmal positional vertigo, it is often worthwhile holding the head back in the extended position for up to a minute. When lowering the patient back, if they do have benign paroxysmal positional vertigo, they can find this very traumatic. If they do find it traumatic, they can close their eyes very tightly. This makes it very difficult to assess any eye movements. To stop patients from closing their eyes, I explain to them that it's very important that they keep their eyes open. Sometimes I ask patients to look at my nose whilst I lower their head down. It is important to perform the Dix-Hallpike manoeuvre with the head both in the left and right lateral positions. I usually perform the Dix-Hallpike manoeuvre on the side that is asymptomatic first. The Epley manoeuvre.
Yeah, and then the last video is the Epley maneuver. Okay.
There are a number of treatments and a number of manoeuvres to treat benign paroxysmal positional vertigo. However, the Epley manoeuvre is the most well established and it's the test that's been proven to be successful in this condition. The first part of the Epley manoeuvre is essentially performing the Dix-Hallpike manoeuvre. Once the head has been extended, I always make sure that if the patient is feeling dizzy or I see some nystagmus, I wait for this to completely resolve before continuing to perform the next stage of the manoeuvre. The head is turned 90 degrees towards the opposite shoulder. This means that the head now lies 45 degrees relative to the vertical plane. You can relax your arms now. What I'd like you to do in your own time is to roll onto your left hand side and just let me support your head. Whilst the patient is turning, the head is rotated a further 90 degrees in the same direction. Finally, the patient is asked to sit up with their legs over the side of the couch. During this manoeuvre, I like to take control of the head so that I can position it as I would like it to be. At the end of a manoeuvre, I ask the patient to finish so that their chin is sitting nicely on their chest.
A dry powder device. Okay, and this is called.
Yeah, I think that was the last important video that I want to share with you, doctors. Let me just see if, yeah. I hope it was useful. Any questions? Let me just open. Anyone have any question, doctors? I'm more than happy to answer. No? It was boring? Yeah. I hope you learned something. I know it's not an easy not an easy lecture, okay, because a lot of information, and maybe a lot of us are not doing a lot of you are not doing the hint test in your day-to-day practice, but that is something I used to do since